Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Centre for Studies in Aging. These webcasts are made possible thanks to the generosity of our donors. So today's topic, which is one that's been requested quite frequently, is what role does genetics play in dementia? My guests are Dr. Laura Robb, a certified genetic counselor at the McGill Research Centre for Studies in Aging, where she contacts families to assess their risk of hereditary types of dementia, informs them of implications, and guides them towards appropriate medical follow-up. She is also involved in recruiting people from identified families into the Registry on Early Onset Alzheimer Disease in Canada and into the Dominantly Inherited Alzheimer Network. My other guest is Dr. Pedro Rosa-Neto. He is the director of the McGill University Research Centre for Studies in Aging. He is a clinical neurologist with expertise in the quantification of dementia pathophysiology and preclinical diagnosis of Alzheimer's disease using biomarkers. And he is also one of 4 co-authors of the 2021 and 2022 World Alzheimer's Reports, along with myself and Dr. Serge Gauthier and Dr. José Moret, so a true member of our team. Ms. Robb and Dr. Rosa-Neto will speak about genetic testing to assess the risk of hereditary types of dementia. They will address the role of genetics in the development of dementia, the benefits and challenges of genetic testing, the process for genetic screening, and what happens when someone tests positive. Welcome to McGill Cares.
Thanks so much for that introduction, Claire. So the question that I'm asking today is, what role does genetics play in dementia? And other questions we're going to answer today are, what are known risk factors for Alzheimer's disease? How are genetic factors involved in Alzheimer's disease? And when is genetic counseling and genetic testing considered? So let's look at some known risk factors for Alzheimer's. We know we have non-modifiable risk factors, modifiable risk factors, and other risk factors. Among our non-modifiable risk factors are our age. Unfortunately, we can't control our age, our family history and our genetics, our gender, and other medical conditions that we might have, such as Parkinson's, multiple sclerosis, kidney disease, HIV, and Down syndrome. Of course, this is where our question comes in today. Our genetics does play a factor. Some of our modifiable risk factors include smoking, high blood pressure, diabetes, high cholesterol, obesity, diet, lack of physical activity. And other risk factors may include alcohol, low levels of formal education, depression, and head injuries. So how are these genetic factors that we mentioned involved in Alzheimer's disease? There are various types of Alzheimer's disease. The great majority, shown here in green, are what we call sporadic Alzheimer's disease. Sporadic because there doesn't seem to be any evident cause or family history. So at least 75% of Alzheimer's is sporadic. And then there's late onset that may be familial, and a very, very small proportion that are early onset familial Alzheimer's. Sporadic Alzheimer's, the most common, is mostly late onset Alzheimer's. Sometimes it can be early onset Alzheimer's, and early onset Alzheimer's we define as having symptoms prior to age 65. Essentially, we know that for everyone in the general population, each one of us, the lifetime risk of having Alzheimer's is 10 to 12% if we all live long enough. So essentially, more than 1 in 10 of us will have Alzheimer's. Inheritance is complex. So we can talk about genetic factors and environmental factors. And here, the balls that are in yellow are the genetic factors. And you can see I'm using an analogy of a cup. And essentially, your cup fills up with your factors. And when the cup overflows, that's when you have the condition. So we all have some genetic factors. And then during our lifetime, we collect various environmental factors. And as I said, when the cup overflows, this is when the moment we become affected. When we talk about late onset Alzheimer's, familial Alzheimer's disease, this is characterized for when we have more than one family member and possibly more than one generation in the family where Alzheimer's disease is presenting. About 15 to 25% of Alzheimer's is in this category. And in this situation, because it's not sporadic, there is a family history. First degree relatives, that means children, brothers, and sisters, have about a 15 to 39% lifetime risk of developing Alzheimer's disease. And this is about 2 to 4 times the population risk. Looking at our diagram again, it's complex inheritance again. And you can see here that we all have different levels of genetic factors. Some of us might have just a little bit. Some of us might have a little bit more. And some of us have a great deal of genetic factors. But again, it takes the genetic factors in combination with environmental factors for our cup to overflow and for Alzheimer's to become present. When we look at early onset familial Alzheimer's disease, again, this is a very rare condition. It's only about 1 to 5% of all cases. And this is characterized by Alzheimer's in at least 3 related family members in 2 or more generations, again, under the age of 65 years old. This is a very strongly genetic condition. First degree relatives are at a 50% lifetime risk of developing Alzheimer's. We're able to find clear genetic causes in about 40 to 80% of the families that we investigate. And in these families, there's one strong genetic factor in one of these 3 genes, PCN1, PCN2, or APP. And those are the genes that we're currently aware of. So we'll go back to a little genetics 101 to explain genes. Our body is made up of millions of cells, and in each cell of our body, there is what we call a nucleus, which is the central part of the cell, which contains our genetic information. Our genetic information is packaged into what we call chromosomes, which is what we can actually see under the microscope. And the chromosomes are made up of long, long strands of DNA that are packaged together. And in this DNA, a long strand of DNA, we have our genes. The analogy I like to use is that our set of chromosomes, we have 23 pairs of chromosomes, is like a book. And each chromosome is like a chapter. And the genes are like the sentences in this chapter. So each gene has a sentence with a specific meaning, which is actually a recipe for a specific protein in the body. When there's a change in this sentence, a simple word change, it changes the function of the protein, and the protein may not function the same way, and so conditions can occur. So this is the last image here. When you have a specific little change, it can change what we call a variant or mutation. This can cause genetic hereditary conditions to occur. So here is my diagram again of DNA. So normally in this place in the DNA, you'd have this little green bar, green circle here. But in this other one beside it, you have a little yellow bar. So there's been a genetic change. We know that we all have 2 copies of every gene in our body. One copy comes from our mother, one copy comes from our father. So there are 3 possible combinations. Either we can have up top here 2 genes without causal mutations, or 1 gene with a mutation and 1 gene without, or 2 genes with causal mutations. In these conditions that we're talking about, this is actually very, very rare. So we're mostly talking about either having no causal mutations or 1 copy of a causal mutation. So this is our diagram for describing how genetic factors are transmitted in families. So here the man up above is someone who is affected with the genetic condition, this early onset Alzheimer's. He has 1 genetic mutation in 1 copy of his gene, and the other copy does not. His partner does not have any mutations. When he has children, there's a 50% chance for him to pass on this mutation to his children, boys or girls. And you can see this, so it's essentially the risks are 50% with every generation if the gene is there. If a child has not inherited the gene, then the gene does not get passed on, the history stops there. So when do we consider genetic testing? I'm going to talk about 3 different situations. Genetic testing for an affected person, genetic testing for an unaffected family member, when there is a known genetic cause found in the family. This is called predictive or pre-symptomatic testing. And then genetic testing for factors which are not diagnostic, but might raise or lower one's risk of Alzheimer's disease. So firstly, let's talk about genetic testing. If we have a family history of somebody comes in with suspected early onset Alzheimer's, and there's a family history, then it is valuable for us to consider genetic testing for them, because it might give us an explanation for their condition. And it may be valuable in considering specific treatments or possibly research clinical trials. Also, if we find a specific genetic cause for this person, then testing can be considered for other relatives. Should their children or their siblings wish to have this information, then genetic testing could be considered. On the other hand, if a genetic test is for this affected person does not show a mutation, it doesn't 100% eliminate the possibility of a hereditary condition. We can't, there are probably genes we don't know yet, genetic factors we're completely unaware of. So we have limits in what we can do right now, and obviously these things evolve in time. So if we do find a specific what we call a causal mutation that explains the condition in our affected person, then we can consider predictive testing for family members. And the results for family members are a little bit more clear. Essentially, if the test shows the presence of the family mutation, this confirms that this person is at risk themselves of presenting Alzheimer's, a relatively high risk. It's all, and at a certain age. And this may clarify other risks for other people, such as their own descendants. On the other hand, if the test does not show that the family mutation is present, then this person does not have an increased risk for Alzheimer's. So it's essentially a pretty black and white test that shows if a clear risk is there or if there is no clear risk. Some of the personal motivations for considering genetic testing, and this is sort of some motivations I've gleaned over different types of genetic testing, maybe for heart conditions, cancer, and Alzheimer's. But basically, sometimes somebody might say, okay, well, I know my father has this condition. I'm a little bit worried that I might have memory issues, so I'm going to consider testing because of that. Sometimes people just want to find out their personal risk, or they want to find out the risk for other family members. They want to make sure that their children are aware if there are risks. Some people might want to do the testing to reduce their worry. If they don't have the genetic factor, then they know that their risk is the same as the general population, for example. And it might be helpful to find out about possible medical prevention or treatment options, help with general planning for the future. Who do you want to talk about? What kind of care plan you want to put in place? Some people want to do testing because it'll help research, and it may actually give them access to clinical trials of new medications out there. Sometimes it's advice from their physician or advice from a family or a friend. In early onset Alzheimer's, the most common reasons for testing seem to be the presence of symptoms, helping to plan for the future, and access to clinical trials and helping research. There are reasons, of course, for declining the test. Certainly, a test, the result might have an emotional impact on yourself or on your family members with regards to fear, anxiety, depression. What kind of influence will it have in your life decisions or your plans? Some people feel that they can emotionally cope with having an increased risk without testing. Some people live better with uncertainty. Sometimes the timing isn't right. And someone might say, I don't want to do this testing now, but maybe I'll wait till after I've had my children or when my children are grown, and that might be a better timing for me to consider this test. And we're all busy. We all have other things going on in our lives, and some people may be too occupied with other issues in their family. Time constraints are listed. Taking the time to get informed, have the genetic counseling, talk about the testing, and have the results. It all takes time, and some people say that may be a reason not to do it. And some people may find that there are unclear benefits of doing this risk assessment than genetic testing. Sometimes there are concerns about insurance discrimination, and some people list the cost of the test. Well, this is more in the United States than here, but these are all issues that people consider when they're going ahead with consideration of testing. All this to say that the decision to test or not to test is very highly personal, and it's very important to obtain the information about the test, what it will tell you, what it won't tell you, and understand it, and then give what we call informed consent. So you're going ahead with the test with this knowledge and saying, I know what this means to me, and I do want to go ahead with this. Okay, so now I want to talk a little bit about genetic testing for susceptibility factors. And this is a little bit different than the testing we've been looking at, because we're not talking about clear causal genetic factors. We're talking about genetic factors that give an increased risk for Alzheimer's disease. And some people may have heard of ApoE testing, and I'm going to talk a little bit about polygenic risk score. So ApoE is a genetic factor, and there are three forms of this gene, essentially E2, E3, and E4. E2 is a rare form, and actually, if you have this, it reduces your risk of Alzheimer's. E3 is sort of a more neutral form and doesn't seem to increase our risk or decrease our risk. E4, which is present in about 10 to 15% of the population, is found to increase the risk for Alzheimer's disease. So we all have 2 copies of every gene, as I mentioned before. So you can have various combinations, but any combination with E4 in it may give an increased risk for Alzheimer's. However, this general type of testing is used in persons who have Alzheimer's disease, but it isn't generally recommended for other people because it really doesn't tell you anything about a clear risk. It will tell you if you have a susceptibility, but it can't predict if you're going to have Alzheimer's or not. There are people who have E4 and will never get Alzheimer's in their life. So this is a tool that's been used, but it's not really something that we want to, that is clearly recommended for the general population. Essentially, multiple factors are involved in presenting Alzheimer's. And we can talk again about our cup, where we have genetic factors, and then we add in other factors, our age, that again, we can't control that. That's non-modifiable factor. And then factors in the environment, lifestyle, and diseases that sort of add up. And eventually, one person who starts with just genetic factors will get to a point where their cup overflows and they will have the condition. Talking about something called polygenic risk score. This is a test where you could conceivably, it's not a test that exists right now, but polygenic scores are being looked at for various conditions, Alzheimer's disease, breast cancer, cardiac conditions. And this is a test where essentially if you do a test, you could say where you fall on the range of the population. Are you at a low risk of having Alzheimer's, or is your risk higher? And basically you can do this by measuring a certain number of genetic factors. Obviously your environmental factors will be on top of that. And if you knew you were at a certain level, then possibly you could make lifestyle changes and reduce your risk of ever getting to that threshold level. And if you didn't take any preventative measures, then maybe the disease would occur. So essentially the way a polygenic risk score occurs is you do a blood test and you look at many, many different factors. So if you look here, person 1 might have a specific letter C in one position, and another person might have another letter T. So that's just a genetic change. And by itself, this genetic change does not cause Alzheimer's. However, if we look at many, many, many of these changes, there may be some associations in certain persons who have higher risks, and we might be able to put all this information together and come up with a report and say, okay, someone may be at a low risk of Alzheimer's disease, or a moderate risk, or a high risk. At this point in time, this is something that's out there in research, but is not currently available. And I think the most important thing to think about is in this type of susceptibility testing is, would you consider doing a test like this? If it did exist, would you want to do the test? What would you do with the information? Who would you want to tell or not tell about this? So essentially, in conclusion, this is a New York Times article that actually talked about people who had ApoE changes and how they were getting information on what it meant for them. Essentially, genetic factors are associated with Alzheimer's, and genetic testing is indicated, but only in certain persons and certain families. For the great majority of people, however, our genes are only one of the factors affecting our risk for dementia, and other factors such as age, lifestyle are also involved. We can't change our age or our genes, but research has shown that up to 1/3 of cases may be avoided through lifestyle changes. And I know a lot of you have probably always seen these, but there are lots of tips out there on various Alzheimer's websites that talk about ways to reduce your risk of Alzheimer's. Thank you so much for your interest.
Dr. Robb, what an excellent presentation. I mean, I think this was the first time I really understood all, like the whole medical terminology, and I love the way you used the cups so that we could really understand, like, you know, the mixing of the cups and how does it all add up to our risks. Dr. Robb, thanks again for this amazing presentation. And I actually have some questions for the two of you. And Dr. Rosa-Neto, since you're with us as well, and I know that you're the director of the McGill University Research Centre for Studies in Aging, can you just spend a little bit of time explaining to us what, you know, your center does, and does the testing take place at the center?
Of course. Thank you so much for your question. And the center is organized in such a way that we can provide care for a specific population. As Laura was explaining, most of the cases of patients suffering from dementia, they have something that they call sporadic Alzheimer's disease. But we have a special program devoted to individuals who have a heavy load of individuals affected in the family. So this is not only for Alzheimer's disease, but also for other types of dementia, such as frontotemporal dementia and other Down syndrome, and also other genetic forms of dementia.
So you showed a lot of the reasons for testing or not. So people listening today, what's the process to make an appointment? Like what is the process? How can they make an appointment? What's the cost? Could you give us some details on that aspect?
To have an appointment, we need a referral from a family doctor. And from there, you know, there are several types of patients. There are patients looking for the risk to develop the disease, and others, they are searching for a diagnosis. So we have in our clinic a group of physicians that are devoted to answer these questions. And we also have a genetic counselor, we have psychometrics, and we can provide a comprehensive assessment and indicate whether a specific type of individual carry the genes that are associated with the disease. So we also can offer to our patients the possibility of experimental therapies, because we don't know much about the causes of Alzheimer's disease in the sporadic cases, but in genetic cases, we know exactly where the problem is. And because of that, we can offer to our patients the opportunity to engage in specific programs that are essentially therapies targeting specific changes in the genes, on the hopes that we could stop the process that will cause dementia and or Alzheimer's disease. Laura, do you have anything to add?
No, I think essentially the way that process happens is someone's assessed by our clinic or by their own neurologist, and then they're referred into our center. I generally take the part of doing a family history, finding out who in the family may have similar conditions, and this gives us an idea of whether or not genetic testing might be pertinent for this person or not. And then the person is seen by a team, and we decide, do we want to do genetic testing for them or not? Is it appropriate or is it not appropriate? As I said, these conditions are relatively rare, but when we do find them, testing can give us an explanation and a way to evaluate other people in the family.
So just to be clear, so you sit down with a person, you do a thorough assessment, family history, you know, and then is the test a blood test? Like what is the test?
It's generally done in a blood test. The reality is any cell in our body will have our DNA. So we can do a saliva test. We can do what they call a buccal test, where you scrape cells from the inside of your mouth. But standardly, it is, yes, a blood test. Most laboratories are doing blood tests. We don't do the testing at our own center. We have to send out to labs who are specialized in this condition. But if we feel like it's appropriate, then we will organize the genetic testing. So.
And is there a waiting list to do this genetic testing right now?
No, there is no necessarily a waiting list. Again, you are talking about cases
to get an appointment. To get an appointment.
Yeah, to get an appointment, there is not necessarily a waiting list. You are seeing the patients in the time frame of a few weeks.
Okay, and then how long does it take to get the results approximately?
It's about 1 to 2 months to get results. The sample's sent out, we get the result back in, we look at it and we say, okay, let's have an appointment and discuss what this means. So about 1 to 2 months.
So I'm just throwing this question out there. So let's say I've decided to go and do this test, and like I was looking at your slides about weighing, do I test or do I not test, especially since it's an illness where there really isn't any cure, right? A lot of people say that, like, why would I get tested if there's no cure? But I've made the decision to do it. I'm now with you in your office and you're giving me the results. Is it possible that I would have a catastrophic reaction, even though I thought I was emotionally prepared? And what I mean by catastrophic, that, it's a real shock. Is there a team of people at your center that would be there to support me?
Absolutely. Of course. And this is the reason we talk about the testing beforehand. We say, this is what the testing could mean and not mean. Is it a right decision to do this in your life right now? And I think it essentially comes, if we think it's appropriate, then it's still your choice to do the test or not. We can't say you have to do this test. And so I think that absolutely our team is there to support. We see a lot of families with this condition, and we have dealt with this a great deal. So our entire team is there to support anyone through these decisions and results.
Okay. And just one final question. I mean, I understand that the costs probably vary per province, or is this test covered by insurance, public insurance, private insurance, and also what is the approximate cost to do the test?
Testing is covered by Medicare. And at this point in time, the testing that we're doing, I'm talking specifically testing for early onset Alzheimer's disease when there's a very strong family history. That is covered by Medicare. We make an application to the government, and this is always covered. So there is no personal cost to the patient at this point in time.
Okay. Well, we will make sure to include a link under the resources section of the McGill Dementia Education Program's website, so that they could get all the information in terms of how to contact the McGill University Research Centre for Studies in Aging if they would like to get more information and go through the process. Thank you so much to the two of you for being here on McGill Cares today, and really what an excellent presentation. Thank you.
Thank you.
This webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. If you would like to make a contribution to our program or for more information, please visit us at mcgill.ca/dementia. And if you would like to join our mailing list to be notified about upcoming episodes of McGill Cares, as well as other important programs and resources, you can email us at dementia@mcgill.ca. Thank you for watching.